Good afternoon. My name is Corey Miller. I'm the Division Chief of Pediatric Neurology. Just, I guess, a little background. We've been here for 12 or 13 years or something like that. You kind of lose track over time. And historically, the adult stroke service had handled the pediatric stroke service as well. And then with some of the transitions that became less established. So, I've talked with Dr. Kassab on several occasions about maybe trying to look at some of the nuts and bolts about this. So ultimately, this is probably going to be the least treatment-directed discussion anybody's ever had on stroke, just because I haven't done that since I was like an adult resident 4 years ago that I care to think about. But I do think that some of the etiology, as well as just some of the incidence of stroke in the pediatric population, is very interesting to discuss. Like I said, more than anything, I hope that we sort of open up a discussion about trying to take care of these patients. There's not many of them, and I think that's the main thrust behind a whole lot of this. With that, we'll get moving. So as far as disclosures go, I've been a speaker for Ipsen. They make Dysport. I will not be discussing the use of Dysport at all during this talk today. I've served as an expert witness before in various trials, and we're not going to discuss it at great length, but I mean, TPA and thrombectomy are completely off-label for pediatrics, patients under 18. So, like I said, I'm not going to go into a whole lot of detail with that, having very little experience with it, A, and B, there's not a whole lot of data on that. And we'll discuss the one trial that they had to look at some of the stroke treatments. They closed down because they just couldn't get enough patients to keep the trial going. And like I said, although I won't try to persuade you to use Dysport, I will try to persuade y'all into looking at maybe helping us with the pediatric stroke going forward. So it's not completely without motive that I'm up here. Although you'll always hear, pediatricians, their favorite thing is kids aren't little adults, and I'm fully aware of that. But for stroke in particular, the magnitude of this problem for the adult population and for the pediatric population is just unbelievably different. And not to just sit here and read facts from you, but I mean, almost 800,000 strokes in adult populations in the United States. And interestingly, whereas like for adult stroke incidence, it increases as you get older. There's, more 30 to 120 in patients age 35 to 44. And then as you get older, the 65 to 74-year-old population, I mean, significantly more at 670 to almost 1,000 per 100,000. In the pediatric population, meaning from the neonatal period to 18 years, it's like 1,000 strokes in the entire country each year. So very, 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 very infrequent. Kind of an interesting thing that I don't even know that I was actually aware of, although I guess intuitively in my own practice, I think I probably have experienced this without even thinking about it. But the incidence of strokes actually reduces as you get older. So the preterm babies, the neonates, actually it's not necessarily all that uncommon. But in the kids 1 month to 18 years, it's only 13 per 100,000 per the data that I was getting. So it's kind of the opposite with adults. This is sort of a breakdown of the types of strokes that you run into in the various populations. With adult strokes, the vast majority are ischemic strokes. at 87%. And then hemorrhagic and subarachnoid are at least reportedly a lot less common. With pediatric strokes, most of the data that I looked at had about 50-50 distribution between hemorrhagic and ischemic strokes. The risk factors are also very, very different in these two populations. As I'm sure you all are well aware, I mean, the overwhelming majority of adult strokes are just related to cardiovascular disease and atherosclerosis. And I guess with AFib and various arrhythmias also sort of provoking strokes in the adult population. In the pediatric population, a lot of the strokes are ultimately cardiac in nature, and not just cardiac, in the cardiovascular sort of a situation, but a lot of the congenital heart abnormality children, your tetralogy of Fallot kids and the various other heart defects that they can have are really strongly predisposed to strokes. And in fact, in my outpatient population, probably the majority of the kids I've seen with strokes probably, I think, had a stroke in the midst of their repair of their cardiac defect or shortly thereafter. So I mean, that's actually a pretty common source for stroke in the pediatric time period. Sickle cell disease also is a really common source of strokes as well. I don't know if they don't trickle over into my clinic as much, or maybe it's better treated here than it was in Winston-Salem, but you just don't see that as much personally, but it is still a really very well recognized source of strokes in the pediatric population. And then you have trauma and various infections as far as disease entities that are associated with strokes. I mean, a lot of the pediatric strokes end up being idiopathic. This is some information about the morbidity and mortality of strokes. Some of it's actually fairly comparable, I think. The data I found indicated that ischemic strokes are about 10% fatal in the adult population, whereas hemorrhagic strokes are fatal about a third of the time. But nationwide, there are a lot of survivors of adult stroke at almost 6.5 million people. However, the morbidity is still fairly high, with reportedly only about a third being able to ambulate after they've had a stroke, and about 25% being dependent on others for their activities of daily living. With kids, ischemic strokes are also about 10%, and hemorrhagic strokes are at about 25% mortality. With the kids, about 2/3 will have a persistent neurologic issue. Most of this is going to, or at least from my experience, has been either with seizures or with persistent developmental delay or intellectual deficits. One point that was always emphasized in the literature, though, is the difference between a 85-year-old patient being dependent on others for the rest of their lives and a 5-year-old kid who is potentially dependent. So although the nature of their injury may be very similar, the duration of how long they're going to require care is a lot longer. A lot of these kids, if they don't have persistent strokes, there's no reason why they're not going to make it well into their 30s, 40s, and 50s. So then you've got 50 years of disability versus 5 or 10 years or whatever. But it's just based on when it happens and what your natural life expectancy is. All that is to say is that it is important to recognize stroke in a pediatric population, as well as when appropriate, to try to intervene. I was going to talk a little bit more about ischemic stroke in the pediatric population. According to the literature, most are related to some sort of an arteriopathy. The most common entity they were discussing was a focal cerebral arteriopathy. I don't have a whole lot of experience with treating this. I'm going to have to go with what I was able to read, but they said a lot of times it's following an upper respiratory infection, and then they'll have some sort of a focal stroke. Vasculitis, we have seen that before. I think that's, I mean, probably a similar process whenever I've experienced it is to the adult, where you find the underlying pathology, treat that. I don't know how much moya the adult population runs into. So I'll talk a little bit about that. I mean, that is something that I think is kind of peculiar to the pediatric population. There's a lot of predisposing causes for it, where you will have what they call moya syndrome, which is where it's secondary. I think that I've seen it twice in my entire time of being a neurologist. One time it was a kid with sickle cell. And the thought is that they just sort of slowly occlude the internal carotid, and then they'll get collateral vascularization around it. And it gives particularly an arteriogram, like an appearance of what they call a puff of smoke, which is what moya stands for in Japanese. In the pediatric population, they do see it more in children of Asian descent. It's not common. Like I said, I think I've seen it twice. One of the kids had sickle. I think the other child, as best I can recall, we never really identified an underlying cause. So that would be, I guess, the more appropriate term would be moya disease, when you don't have a good primary reason to label it. About 30% of pediatric ischemic strokes are of a cardiac in nature. That goes back to what I was saying with the congenital heart anomalies. And a lot of times when they're having their surgeries, they'll have clots and a stroke. And then some of the same predisposing factors that we used to see in our young adults with protein C and protein S and factor V Leiden. And then unfortunately, there are some systemic disorders that are also associated with ischemic strokes or injuries that look like ischemic strokes, like MELAS, CADASIL. And then also, it's not uncommon to see strokes associated with sepsis. Another type of stroke that you will occasionally see in pediatric patients is just like a venous sinus thrombosis. My understanding is this seems like it's very similar in the pediatric population as it is with the adult population, where it's usually a preceding event such as an infection, like an indolent infection, or infections of the sinuses that extend intracranially and are associated with thrombosis. I haven't seen it with like oral contraceptive pills and things like that in the pediatric population. Their exposure to that's not quite as much. So I think the frequency is probably reduced because of that. But the same risk factors that the adult population has with those kinds of medications, the pediatric population likewise is at risk for a venous sinus thrombosis. And then also just other prothrombotic conditions. In surgery, sometimes I've seen it before where this would be something that is peculiar to the pediatric population, is when they're doing, you get the kids with the premature closure of their sutures. So a lot of times plastics will go in there and kind of fracture it and stretch it out. And I've seen that where sometimes you'll have a venous sinus thrombosis following that type of a procedure. And I think that's just the invasive nature of that procedure. But again, that's also not common, fortunately. And then the hemorrhagic strokes, I think overall the underlying etiology of pediatric hemorrhagic strokes and adult hemas look pretty similar to me as far as AVMs and aneurysms. Fortunately, you don't see a whole lot of aneurysms in the pediatric population just because the underlying cause of why a adult would have an aneurysm, being like with hypertension chronically, you don't really see in the pediatric population. Whereas in the adult population or in the pediatric population, you might be more likely to see somebody with like a Marfan syndrome or some other sort of musculo or connective tissue disorder who has aberrant arterial wall formation. And in my previous discussions, we had talked about what concerns for stroke mimics, and probably even a better, I don't know if it's a, I don't know if stroke mimic is really the right word. Probably chief complaints that frequently are formulated to sound like a stroke that are also not stroke. I still haven't found a good way to say mimics, because mimics, it's like, oh, there's this, it really looks like a stroke, but it's not. Whereas I think it's just things that should be on your differential when stroke is also on your differential, maybe the better way of putting this. One of the, when I was doing my literature search, and I remember this from way back when I was a resident. In adult stroke, you've got, you know, the stroke scale, and that's what you're basing a lot of your decision making on who's going to get thrombolytics or who's going to get whatever treatment they're going to get. And it also helps you predict, well, this is what the outcome is going to be. Well, none of that really exists in pediatrics. They've tried, and it's ultimately just on a whole lot of fronts, it's difficult. And one of the papers I'm going to show you or at least discuss in a second, I mean, even finds the physical exam to not be very beneficial at all when you're trying to identify pediatric stroke. This paper looked at, it was not my favorite design or anything like that, but they had sort of prospectively, I guess, when they decided they were going to look into this, collected things that we were considering a stroke mimic. And then they had also looked at retrospectively over the course of years, all the actual strokes that they had. And they tried to look at some of the presenting findings and some of the presenting complaints to see, well, which ones seem to be most likely associated with stroke and which ones seem to be most likely associated with the stroke mimic in a pediatric population. And what they found, at least for pediatrics, was being well the week prior, and then arm weakness, face weakness, and an inability to walk increased the odds, I guess, pre-test that this patient was going to actually have a stroke. And then if you had other symptoms such as stiffness or lethargy, it reduced the risk of it being a stroke. Well, in a way, that kind of almost makes sense to me, at least, because whenever I start seeing, well, lethargy and stiffness, and other, I mean, you start worrying about more infectious etiologies anyway, which, you know, brings into the, well, is this some sort of a febrile seizure with the Todd's paralysis or some other problem that's got nothing to do with stroke? But I think this is different just from the adult world. When y'all are going in to see somebody with a stroke, they usually have pretty obvious weakness, or they have pretty obvious dysarthria, which is what brought them in. One interesting point that I think is worth noting here is in this, the study had referenced some adult literature where they found that seizures increased the odds in the adult population of it being a mimic. And reviewing the literature, I don't have a good sense for how many adult strokes are associated with seizures. I mean, I know it can happen, but in the pediatric realm, it actually is pretty common, like somewhere around 25% either have a clinical seizure or subclinical seizure, which was, I don't know that I knew that before this, but they think it has to do with the younger brain is just a little more prone to going into is the electrical activity is more excitable, and whenever it gets disrupted with stroke, seizures are more likely. But I will, yet another reason to get more continuous EEGs, which I'm sure Dr. McKay likes. I know Dr. Ireland will love that little tidbit, but like I said, I don't know if that goes with y'all's experience with adult strokes and subsequent seizures or not. But this study I thought was interesting. Overall, I thought the design of this was a little more interesting, but the numbers were really poor. But this was only looking at 59 patients that were enrolled altogether, and only about 14 of them actually had a stroke. So the numbers aren't great, but they did a similar thing where they were trying to look at, well, what sort of signs and symptoms seem to correlate more with stroke and more with a non-stroke process. And on this particular study, which again was limited, they did not find that weakness was even necessarily associated with the stroke, and then overall, they didn't find the physical exam to be very helpful, which is extremely unsettling when you think about it, when you're going down to the ER to see these patients. However, there's part of me that feels a little better about that, because there's a lot of times where you're done seeing people and you're going to do the workup and you're not exactly sure how it's going to shake out. I mean, is it going to be ADM? Is it going to be a stroke? Is it going to be a Todd's paralysis? And sometimes it's nice to realize other people run into a situation where they don't always find all of their history and their physical to have the exact answer right in front of them. This is talking about this same study though, and this just sort of differentiates. They sort of clustered this maybe more than I would have wanted to do, but out of their 59 patients, 24% actually had a stroke when what they had done was patients who came in, this is a team out of Detroit. They had started a stroke clinical pathway for their pediatric patients. So you would come in, they would initiate a stroke code. And then, so they had just taken 59 patients who had come in through this pathway and then looked at what their overall disposition was, what their overall diagnosis was. And out of the people who came in, only 24% actually had a stroke. 20% had functional neurologic disorders. And I don't know exactly how, they didn't really break down what they meant by transient neurologic deficit. And whether that fits into functional or whether that fits into TIA was not really well explained, in my opinion. So that's kind of, I don't know exactly what to do with those numbers. But a lot of them had migraine, and a lot had seizure and Todd's paralysis. And particularly when you're looking at, well, a pretty high number, almost just as many people had a functional neurologic disorder as who actually had a clinical stroke. Not all of the things that you might find are necessarily benign, though. I mean, there's a pretty good number that may turn out to have ADM when they start presenting with what looks like a stroke. There's probably, I would suspect, like a Guillain-Barré would also be a finding that somebody may present with as a stroke protocol, but it turns out to be maybe something else. The take-home message I kept getting in all of the literature I was reviewing, though, is that your pretest probability of somebody presenting with a stroke in the pediatric population is actually pretty low. One of them had even found numbers as low as 93% did not have a stroke, even though they had performed a stroke protocol. That was by far the highest non-stroke. Most of the others that were in the 20 to 25% range, like the 59, or like the study out of Detroit. So far we've got a very kind of a rare entity, like with 1,000 in the whole country over the course of a year. And then also when you look at all the things that present with it, again, it's rare. As far as attempts made to have discussions about treating pediatric stroke, whereas with adults, you don't always have to get the MRI before treating and before calling a stroke a stroke. In pediatrics, it's mandatory. And I think a lot of that has to do with the pretest possibility being so low that you need something to hang your hat on to prove that there is some sort of ischemia before moving forward. Most of the accepted literature was discussing getting DWI and ADC, gradient echo, and most even wanted an MRA as well, to try to find how far out in the neurovasculature the clot, where the clot landed or formed. This particular article that I'm referencing here was discussing, it had sent out a survey to like, I guess, most of the children's hospitals, just to sort of see what people were doing and what their goals were. So this is, I mean, I don't even know that this is expert consensus opinion level data here, but I always have I've always found it nice to know what other people are doing and what other programs are doing. And they also seem to think that trying to get the MRI in 60 minutes or less was fairly appropriate. The other issue you run into with pediatric stroke, though, is I don't know that you can sit through 2 hours worth of television and not see an ad locally for one hospital that's the stroke center. But most of that's all adult guided. And I don't think that most people, when their kid starts not moving their arm well, is immediately, well, let's get up and let's give you your aspirin and let's run to the emergency room. There is usually a lot of delay from the onset of symptoms until they even present to anybody in medicine. I mean, a lot of times they will have had it for a day, they'll go see their pediatrician, and then their pediatrician will send them over to the emergency room. Well, I mean, you're already 36 hours into it by then. Institutional delays in diagnosing pediatric strokes are also extremely common. The amount of effort, it's hard enough to get an MRI just unsedated. Getting a kid to not eat for 6 to 8 hours so that you can give them anesthesia, getting anesthesia in there and getting the MRI all arranged is like a Herculean feat. But it's not just us, it's everybody that has that problem. And then particularly at night, not all places have MRIs that run 24/7. So that, I mean, that's another hurdle that is noted. And then also, I mean, kind of referring back to when the adult stroke service would handle it. I mean, it's rare that you have a pediatric neurologist in-house. I mean, even during the day, I mean, the vast majority of pediatric neurology is outpatient stuff. I mean, headaches, cerebral palsy, epilepsy that's, not necessarily acute. So it's very rare that anybody's in the building. And after at night, it's also extremely rare that anybody's around. Anyway, by the time stroke is diagnosed, it's actually very rare that it's less than 6 hours. And quite often it's over 24 hours in the pediatric population. This is the off-label, I don't have a good internal sense for, apparently some, like the TIPS trial required vessel cutoff before they would institute TPA and various interventions. I don't know that all institutions do that though. I think if you're talking thrombectomy, which I think is the most likely scenario in the pediatric population, because getting somebody in 3 hours is probably going to be unheard of. So you're probably looking at thrombectomy. You probably do need definitive imaging on angiography, so that seems very reasonable to me. And then even the American Heart and Stroke Association is not really supporting a whole lot. I mean, they don't really have a recommendation. I mean, it's sort of, hey, this is controversial. So whether you treat or not is also, I think, a big question, particularly when you look at the relatively high prevalence of thrombotic or of hemorrhagic stroke in pediatrics, when 50% overall are hemorrhagic anyway. Now, I know that the etiology can be a little bit different, but I mean, when compared to adult ischemic stroke, that's at 83%. I mean, that's a big difference. And particularly if half of them are already going to convert, I mean, it's legitimate to be worried about, particularly systemic TPA. Some of the teams, the article that sort of was an article about a survey, just talked about the relative, or the people who are in the various stroke teams. And it usually involves, I mean, not only radiology just for diagnosis, but also interventional radiology for the thrombectomy, if that's the route that's elected. But you've got ER, you've got anesthesia, and then all these kids go to the PICU afterwards. So how much of these teams we would have locally, I mean, PICU is always very helpful. Anesthesia is sometimes a challenge to get in the middle of the night if that's what's required though. Still, I had given a handout out. I'm not sophisticated enough how to translate this into a slide on my PowerPoint, so I apologize to the people who are unable to pick up a slide on the way into the room. But I would think that any sort of a stroke protocol really needs to just start with imaging. If that's where all your decision points are going to be made, that needs to happen. And then also, in my opinion, if adult neurology is involved in this decision-making process, I don't want them called in every single time somebody has stroke on the differential. I want them to have an image to look at that confirms, hey, we need your help here. Even if it's not to proceed forward with treatment, but just to say, yeah, that's what you got. Go to the PICU and intracranial pressure management if necessary, depending on the size and where the stroke's involved. Anyway, I think, as I had mentioned, it's already nationally a very rare sort of a disease. So how much resources you commit to pediatric stroke, I think, is a legitimate question. And I know everybody's like, we got to do everything for the kids, and I understand that. But when you're in an environment with some limited resources, there's only so much you can do. I think that probably and this is just some math I was sort of doing, if you got 1,000 events per year, there's 250 children's hospitals. Our fair share would be 4. However, I think we would probably even have fewer than those because we don't do the cardiac surgery here. We don't have a pediatric chest surgeon. So one of the major drivers we don't have. So I think we probably wouldn't even see 4 a year. But anyway, like I said, I think MRI is definitely necessary before you'd even have a discussion about, does this patient have a stroke and what do we want to do to intervene? And then there's also the nature of you're asking, and I am not necessarily unsympathetic to the whole thing is off label. There's not any guidelines on who gets what. and you end up basing this off your personal experience. And I know in the child neurology department, the personal experience is zero. I mean, it's been 15 years since I looked at it, and talking to the other guys, I mean, most of it has largely been confined to residency. Anyway, so here's a list of my works cited. Do y'all have any questions or anything I maybe went over too quickly or didn't point out, or anything that was interesting? Yes, ma'am.
So how often is it considered that you transfer some of these inpatient strokes up to Vanderbilt's Monroe Carroll?
So we've had that discussion, and I mean, so this, my initial, when this first became an issue, because it always becomes an issue on, like, I don't know, like Saturday at about 2 in the morning. So we need to have a plan on what we're going to do. And my hope was, and I think either way, I don't want to put anybody who has a differential diagnosis. And what I was trying to do with this flow chart was try to come up with a rational way of managing these people through the emergency room. So that was my initial thought was, hey, we'll just package them and ship them. The problem is, you know, and ultimately if they're 24 hours out, that's probably fine. If you're not going to do anything in the hyperacute scenario, I think that's probably okay. Both Vanderbilt and Emory have pediatric stroke specialists. So I wasn't necessarily opposed to that, but that does mean you're not going to do any hyperacute treatment. But I think, which again, it's not FDA approved. So I don't necessarily know that it's wrong to not do that, because I mean, it's off label.
It's more just a question. I worked with Dr. Lori Jordan.
Yeah.
Up at Vanderbilt when I was there. And much of what you have is very similar to how they would run things. It's just a question that I am not certain of the answer here, is how aggressive the interventionalists would be.
Well, I don't know if you've ever talked to those guys, but whenever you ask them, hey, you're going to help, it's like, yeah, we'll do it. And then when it's time to do it, it's like,
Right.
So, you know, and I mean,
that's what I guess what I was getting at, because I know that a lot of the interventionalists up at Vanderbilt who do the adult interventional call do go for some of these pediatric cases if there is the vessel cut off, and you know, sometimes, you know, if you've got that diffusion that's not strongly positive, that isn't the entire area of the vascular territory that is at threat, would consider it even at times out that are more concerning.
Right.
So I guess that I don't know the answer to that in terms of when it, like push comes to shove, like what they feel comfortable with.
Well, I have talked to Dr. Jordan, actually. I mean, we've discussed this already.
Yeah.
And I'm just trying to, and when I talked to Dr. Kassab, I mean, I'm personally still in the process of trying to work this out. I mean, I think.
Well, what did she say about the TPA? Because like the issue becomes dose for age, depending on when they've done the study previously that, you know, didn't have enough enrollment. There was different doses of TPA depending upon the age of the pediatric.
We didn't really get that far into it. I mean, like I said, I was more of it's still at the feasibility.
Sure. What I mean, was that like in general, TPA, unless it was in a trial, no.
Yeah.
That it was more or less plus minus thrombectomy. And that is, of course, like, yes, like getting the vessel cut off, making sure that it's not totally completed. And then it really does come into play with sort of like the comfort level of the interventionalist.
Right. Well, and you'll have to forgive me. I don't, I've been out of this for so long. I don't even have an internal sense for what's the right answer for some of this. Like,
but the truth is that, there are going to be maybe some people that you could potentially convince here, but I think it's like reasonable to be nervous.
Oh yeah, no, I mean, that's ultimately why I'm here. Is I'm nervous about all this. I don't know if that came shining through on my really glossing over some stuff during the exam, but
It is definitely be nervous taking like pediatric patients for thrombectomy, but I think that's the main question I would have is just that if there was a thrombectomy situation, how likely would the interventionalist here be willing to take something versus interventionalists that are affiliated over at Vanderbilt, and how fast could you get them there, by helicopter, I guess.
No, I mean, I think that's probably where, I mean, finding what the decision break point is going to be is probably where a lot of this is going to head. Dr. McKay.
Oh, boy, great talk. This is a question for you and also maybe Dr. Kasab. For these kids who are, 17, weigh 80 kilograms, whatever, like they're kind of almost adults, are they being treated differently than the kids who are maybe 5 years old or, in that scenario, sort of 16, 17, coming out with an ischemic stroke who basically is an adult weight-wise? What are we doing with those kids? I'm just curious. I really don't know.
From my standpoint, I would just love for the ER to be able to separate who's 17 and who's 18. I mean, God forbid them try to figure out what the chief complaint is. But, I mean, that's been an issue for 15 years, and it never gets any better. I mean, because I'm sure, well, anyway. I mean, because that's why step one on my little recommendation is just the 18-year-olds where the 18-year-olds belong and the 17 and less where they belong. I mean, I would just love for people to be in the right hospital. So, I mean, these baby steps. But I mean, I agree. I mean, I don't necessarily know that a 17-year-old is vastly different than an 18-year-old.
Yeah, it seems like there's some gray area there, huh?
Well, I don't know that there is gray area because of what the recommendations are. I mean, they're.
Here's the deal. I gave a TPA to a 4-year-old within a week, and I took 0.7. Don't ask me why I took 0.7, because I was scared to do the 0.9. But if you look at the cascade of the thrombotic cascade for a kid, actually stronger than that. I think the following reason you should give more than 0.9. I was afraid to get this, but the mom said, "You take what you need to do." So it worked fine. I don't know, because I have this case under my belt, I'm willing to do it again. Okay, but I don't know if this is the right answer. There were a lot of trials trying different, dosages. None of them give an answer.
Okay.
So.
Just user experience, whatever you feel comfortable with.
Bottom line is going to come down to what Megan said. I mean, it's going to be an artery included because most of the mechanism is going to be a blood vessel. So you have to have your intervention on board.
And I think most of this is going to be more of a thrombectomy discussion. I know I say TPA, that's just because in my head, that's how you get rid of clots, but it's because I'm a dinosaur. But
I think what I see is that you have no liability from just doing nothing in pediatrics. And a huge liability, especially for adult interventional neurologists that may consider doing something, which, and then the other thing is kind of logically contradictory. Number of children qualifying for off-label intervention. How do you qualify for an off-label intervention? I mean, TPA for depression could be off-label. So, You see, I think a big obstacle with adult interventionalists, not one of them, but
Yeah.
because of that reason.
No, and I think that's part of it. I mean, this is, you're getting a little taste of pediatrics. I mean, but I mean, from a very real, because I've learned over time, because very little of what we do is on label. I mean, if we had like on label, we'd have like phenobarb and Depakote, and so you get used to using things off label. But yeah, I've said that before, like, hey, if we do nothing, we stay within the FDA guidelines, just let them sit there and have a stroke. That doesn't sound good to some folks, So I'm just looking for a pathway, because the time to figure this out is not Saturday at 2 a.m. The time to have a plan. I mean, and if it is, put them on a helicopter and send them where they've got a pediatric stroke person. I that's great.
The pediatric stroke person over there is they can't do the same thing that we can do here. Doesn't make sense.
Yeah, well, I think part of it is that they have interventionalists that they work with in the pediatric stroke clinic at
Yeah.
Vanderbilt that are like on board. They're like, yes, I will take this. They've already kind of like sort of like frontline sort of accepted, like, I will take them if they meet this criteria. It's not going to be something I back out of. There's several of them. Several.
So we need our interventionist buy into this.
Yeah.
Our group is not going to be the problem. We will see these guys. If TPA is the need.
Well, yeah,
to me, if this is my son, I don't want them to spend more time, killing 2 million neurons per minute to arrive to Vanderbilt.
Right.
So if the skills are available here, we should find a way to do it. And intervention becomes the issue. You can give TPA.
I think part of it is just making sure that it's like all the interventionalists are on call that would agree.
Yeah, I don't know.
Well, no, and that's ultimately, I had a fun afternoon getting ping ponged between interventional radiologists before somebody said the guy you need to talk to is not going to talk to you for a couple of weeks. And they oh yeah, it'll be great. We got it. And that's it. It's like, well, I don't know that everybody's on board, but exactly like what you're saying, where you get maybe 2/3 of the people are all in, but
And the time it comes up is the person that's
yeah.
hesitant.
Well, and so, yeah, I think that may be what I need. That may be the exact, you're either all in or you're all out. And I'm fine with either. I just need to know what to do.
Credentials that are the interventionalist credentials. Those procedures under age 18.
It's just a matter of having the right size.
Yeah, they
But-
do interventions, like, 'cause I see some of the pediatric vascular kids, like, within reason, like, I think I've been like, to 14 now, on the outpatient side. So for various reasons, whether it's like an arterial or a venogram, like, I've had them do it. So I know they can do it catheter-wise to that age. And
That was what I got too, is that, as long as we've got the right size catheter, which,
The right size human.
well, that again, it's not my world. I just have to sort of take them at face value, but
yeah, I think that the more that it's specific about time from last normal, what it looks like on the MRI, and then if you get everybody to agree on the interventional side, then that's all tied in. It's not like, oh, we'll just sort of see.
yeah. Well, no, and that's what I've been after. So yeah, that's, well, yeah, thanks.
It's different too, because we don't have, we're not calculating perfusion deficit by MR here, which is, the kids don't get the CTA with the CT perfusion, which is how we risk stratify for intervention. Because the CT contrast, or the CT,
You mean the radiation?
the radiation.
are ways of doing it with MRI.
Right.
And get a stat MRI to make sure this is stroke.
I know, but I'm saying is that protocol, you'd have to like, again, kind of go through the interventional radiology people and be like, hey, like, are we gonna do this new protocol? And get all the text to learn how to do it.
So I guess, I mean, from our group, anyway, so we're not gonna be there.
Okay.
We're ready to see a patient, this is, even consider today, but I mean, thing is, I can go with you and meet with the radiologist and see if they wanna take it all the way, otherwise the patient should be go somewhere else.
Yeah. Okay. No, I mean, I just thanks for telling me what questions I need to be asking. I appreciate it. I mean, that's but they, in my opinion, they should be getting an MRI before we're called or before you're called, before anybody's called, because I have found if you give them a, hey, I'll handle this button, they hit it all the time. So go ahead.
I think there's a question on Zoom.
Oh, how does that happen?
Hey, can you hear me, Dr. Miller? It's Tracy Jennings. Can you hear me? Hello? Hello, hello? Hello, can you hear me?
The other thing is that the majority of these kids are going to be premature.
So, okay, yeah, well,
It's much higher in preemies.
yeah, that there's no way we would involve you in that. I mean, that's that's why this is such a minority of patients, and it's so rare. I mean, we're really talking about not very many, because ultimately you're right. The preemies and the neonates have a lot of the pediatric stroke. Just most of those guys, you don't even know they've had a stroke for 6 months. You know, they're like, so I'm the CP guy, so this is stuff I know about instead of trying to just read about it and tell you something I read about. But, you know, the most common cause of like a pediatric hemiplegic cerebral palsy, it's a full-term kid, everything went good, and they either had a stroke in the newborn period, and that's how you find out that there's an issue, or when they're 6 months old and they're right-handed, well, then you find out, oh, you've had a stroke and you don't use your left side. Well, I mean, the hyperacute, what are you going to do is just not even a factor. So, it's just, there's no thrombectomy or anything like that for that sort of a situation.
The question is,
Oh,
do we have to sedate all pediatric MRI? And it seems like the first step is imaging. How can we improve time frames stored at imaging? Do you have to sedate the patient?
you don't have to sedate the patient. The way that the hospital protocol works is that they want everybody less than 8 years old sedated. So, you know, anybody who's, 8 or up probably isn't going to have to be sedated, as long as they don't have some sort of a comorbidity like autism or, Down syndrome or something where they're going to have a hard time sedating them. And that ends up being the other issue, is that the anesthesiologists really don't like sending people in there who've had anything to eat and drink. And I don't know that most kids these days go more than 1 hour without eating or drinking something. So, the chances of getting a 4-year-old into the MRI, that's, your experience was, miraculous to be able to have that diagnosis in time. Oh, it's a TET. Okay. So anyway, but I think that's also a limiting factor. If you can't get anesthesia and you can't get an MRI because the patient's behavior is going to preclude that, you're just not going to get your MRI. On the flow chart, I have CT if you can't get an MRI. But based on my review of the literature, I would be hesitant to do very much of this without an MRI proven stroke, personally. I hope that answered your question. Did it? Well, thank y'all for your attention. Thank y'all for sitting through all that. I'm sorry that there was a vascular person here that had to listen to that. It's terrible. Embarrassed, but thank you.